Hello, good morning, and welcome. Thank you for joining us for this special episode of House Calls, Real Docs, Real Talk. I'm your host, Sonia Azad, and I don't usually see you guys on Thursdays, but I'm happy that you're here. Today we are closing out the year with a special episode focused on women's health. And for too long, a lot of you know women's health concerns have sort of lagged behind men's, especially in the field of research. Well, now is our chance to catch up, okay? And don't forget that your involvement really does drive our show. And before we go any further, stop, hit that share button, or start a watch party. Let your friends and family know what you're doing today because we want to get them involved as well. Also, throughout the show, we're going to ask you to get involved by answering a few viewer questions. So to respond, all you have to do is text AHA Live to 22333. Don't worry, we don't ask for your name or any other information. It's just a fun and easy way to answer. And if you don't want to text in, you can also participate by simply dropping your answer in the comments section. I've got my eyes on them over here. Okay, let's get started. With me this morning is Dr. Erin Mikos, Director of Women's Cardiovascular Health from Johns Hopkins University School of Medicine. Good morning to you.
Oh, good morning, Sonia. Thank you so much for having me on your show to discuss this really important topic and one that's really near and dear to my heart. So thank you.
Yeah, I was going to say we were chatting a little bit before the show, and certainly this is a very important topic, not just this time of year or right now with COVID-19 lingering, but really it all the time.
Yes, I agree. And that's certainly, we're going to be heading into February, which will be Go Red for Women Heart Month. And so, but I think we should be thinking about women's heart health all year round.
Certainly. And before we start, we want to begin with our first viewer response question. So here it is, viewers. What is the #1 killer of women? Do you think it's breast cancer, leukemia, heart attack, kidney failure, or none of the above? So this is the first opportunity y'all have to drop your answer in the comments section, or you can text in with what you think it is. And Dr. Mikos, it's not that we're saying that any of these causes is necessarily, better than or worse than. I mean, when you're talking about any of these things that are listed, it's awful. But what we're talking about is what we tend to see more commonly. Is that correct?
Yes. The #1 cause of death. Of course, all causes of death are important, but certainly we want to focus on what we can do to prevent mortality in women and improve quality of life and length of life.
Yeah, and I think so far, our viewers, a lot of them are saying cancer, some saying heart disease as well. So why don't we go ahead and let them know what the correct answer here is?
Yeah, so today, still heart disease is the #1 cause of death in women. We've made a lot of progress over the last few decades with a dramatic decline in cardiovascular disease mortality, but it still remains greater than cancer. And then unfortunately, in recent times, we've made some plateauing in this progress that we're no longer making as greater gains in reduction of cardiovascular disease mortality. And there's actually been an uptick, particularly in middle-aged women. Heart disease deaths are on the rise in women aged 45 to 64. So we're losing a little bit of ground here. And this is why we need even more focused attention on prevention.
Certainly. So those of you who answered C, and I see a lot of them in the comments section as well, you got the answer right. Heart disease, the leading cause of death for women in the United States. Okay, let's move on, get started with health in the headlines. So here's how this works. Each week, we select one current headline that ties back to the topic at hand and then ask our expert to respond. And this week's entry comes to us from USA Today. The headline, forewarning here, is grim. Women are more likely than men to develop heart failure or die after a heart attack, study says. So that's the headline. Dr. Mikos, let's bring you in. What is going on here?
Yeah, so this was a study that was just published this month in the American Heart Association's flagship journal called Circulation. And so this study was a large population-based study looking in Alberta, Canada, but I think the findings that they found are very similar across the world and the United States as well. And so what they looked at is patients that were hospitalized for a heart attack between the years of 2002 and 2016. And what they showed is that women, although women on average were older when they presented with a heart attack, and they tended to have more health problems than men, such as they tended to have more diabetes and high blood pressure and kidney disease and lung problems when they had their heart attack. But even after you accounted for those factors, women were more likely to die in the hospital in the setting of their heart attack. And for a certain type of a heart attack called an ST elevation myocardial infarction. And then for both types of heart attacks, women are more likely than men to develop heart failure within the next 5 years after that incident heart attack. So this is really concerning, and it fits with a lot of data we've seen before, that in the setting of a heart attack, women tend to fare worse. So what are the mechanisms? One, as I mentioned, women tend to have more health problems when they have their heart attack, but these disparities still exist even after you account for that. Another issue is I think that women tend to present with a heart attack a little bit later. They sit at home kind of ignoring their symptoms, or perhaps attributing their symptoms to other things like heartburn or anxiety. They might not be thinking that a heart attack could be happening to them. So they get to the hospital a little bit later when the heart attack's a little bit more advanced. And we know that, time is of critical essence to get therapy urgently. And so that might contribute to the poor outcomes also, because they're getting to the hospital later. More concerningly, there are disparities in care and how women are treated with their heart attack compared to men. Now, these gaps are improving over time, but this study and other studies suggest that women are less likely to get procedures, such as coronary vascularization stents being placed in the setting of their heart attack, and they're less likely to be getting some of the standard preventative medications. And this may also contribute to their worse outcomes. And in fact, some of my own research that we presented in one of the Journal of the American Heart Association, we looked at individuals in a US sample, a nationally represented sample of individuals who've had prior cardiovascular disease, a heart attack or stroke. And women were less likely than men to be on statins and aspirins. They were less likely to be on these preventative treatments. And so we need to improve these gaps of care. We also know that women are less likely to be referred to cardiac rehab and to actually enroll in cardiac rehab if they are recommended for that. So we still have work to do to help reduce some of these gaps in care.
And I know this is a big area for, a lot of cardiologists across the country. We're going to dip a little bit more into this later in our show. For now, we want to get to our main segment with live viewer questions in You Ask, We Answer. And as a reminder, you can submit your questions in the comments section or submit them to heart.org/housecalls. So let's get to it. Okay, our first question coming to us from Jen in Battle Creek, Michigan, who asks, what causes high blood pressure in women, and how does high blood pressure impact a woman's health? And Dr. Mikos, I would imagine, depending on what stage of life you're talking about, the answer might be different.
Yeah, so high blood pressure is a major risk factor for heart disease and for stroke. And it's, we call it sort of a silent killer, because a lot of times in the earlier stages, people have no symptoms, and yet this high pressure is contributing to hardening of the arteries and damage to the arteries, which affects the heart and the brain and the kidneys, and also can lead to heart failure. So in many adults, sometimes there is no identifiable cause of the high blood pressure, but we do know that there are risk factors that do increase the risk of high blood pressure, including smoking, being overweight or obese, lack of physical activity, too much salt in the diet, too much alcohol, stress, older age, genetics, family history, chronic kidney disease, sleep apnea. These are all established risk factors for high blood pressures, and many that I mentioned are preventable. We do know that there's racial disparities. Unfortunately, Blacks are twice as likely to have high blood pressure than whites, and these gaps begin, early in life by the age of 40. We do know that women after menopause tend to have more prevalence of high blood pressure, of hypertension, and they're less likely to have blood pressure controlled. So there's a lot of risk factors that are contributing, and many of them can be preventable through a healthy lifestyle throughout one's lifespan. But the important thing is to get screened for high blood pressure, because many people don't know they have high blood pressure unless they get it checked.
I think that's an excellent point because you don't necessarily feel it in your body. Okay, Claudia from Torrance, California wants to know, what can women do to prevent or monitor high blood pressure and specifically preeclampsia?
Yes, I'm glad this brought up preeclampsia. It's such an important issue because many women don't realize that preeclampsia, having a history of that, even if it was 10 or 20 years ago, remote in the past, that is a risk enhancing factor. And it's associated with an increased risk of the mother having an increased risk of heart failure and heart attacks and strokes later in life. So preeclampsia is a problem that begins about 20 weeks into pregnancy, is manifested by high blood pressure and protein in the urine. Again, we don't know all the risk factors for preeclampsia. We think it has to do with how the blood vessels and the placenta are forming and how they respond to hormones. But risk factors for preeclampsia do include having chronic hypertension, so having high blood pressure before the pregnancy is a risk factor, age, one's race, being overweight or obese, and smoking. So again, some of those things, can prevent a preeclampsia in some cases, such as maintaining optimal weight and not smoking and regularly exercising. But if a preeclamptic pregnancy is identified, it's important to have blood pressure monitoring during pregnancy and to work with a pregnancy heart team that involves OBGYN, maternal fetal medicine, cardiology, to help get women safely through pregnancy, because we know that the leading cause of maternal mortality after pregnancy is cardiovascular disease. And that's why women who have a history of preeclampsia, after they deliver, they should get plugged into follow-up care, because they need to realize that their own heart health risk is elevated, and to make sure that they do get the appropriate screening and attention. Because I think after delivery, often the focus, of course, is on the new baby, and we can't forget to ignore the mother's health too.
Okay, let's get to our next question. This one's from Melissa in Monroe, Louisiana. How does menopause affect a woman's risk for heart disease?
Oh, these are good questions. So, on average, women are at lower risk for heart disease before menopause. And we think that's because of the body's natural estrogen levels can help protect the heart by helping making the blood vessels more flexible, more able to dilate, accommodate more blood flow. Although I will note that individuals, women who smoke or have diabetes, they don't have the same kind of benefit of the premenopausal advantage. Now, we know that, when woman goes through menopause, there's this abrupt loss of this protective estrogen. And so particularly women who went through menopause early, before the age of 45, or particularly before the age of 40, we know that these women have a heightened risk of heart disease. And in fact, the recent American Heart Association guidelines have cited early menopause as a risk-enhancing factor. Again, a red flag of a woman who might be at greater risk and more preventative attention. So we do know that blood pressure is more prevalent after menopause in older women, and women are less likely to have blood pressure controlled. So again, this needs appropriate screening, and we need to make sure that we're doing a better job of controlling high blood pressure, because this is a major risk factor for stroke and for atrial fibrillation and heart failure in older women.
Yeah, and I can't help but think my mom, who does have high blood pressure, also has diabetes. So managing both of these things together in, her 70s now is very difficult to watch. And I think that, it's something that you may not be thinking about when you're 20, 30, 40, but when you're 60 and 70, it feels like it all hits at one time.
Right. But I want to mention that even though women's risk of heart disease does go up after menopause, we know that women on average tend to get heart disease later in life. But I want to keep emphasizing, though, that young women can still get heart disease. I mentioned earlier that the greatest growing rate of heart disease mortality is actually in middle-aged women. And so I think sometimes clinicians don't really think about maybe screening for risk factors until after menopause. And, this is, a mistake. We need to screen risk factors early in life, not only to identify the high blood pressure earlier in women, but for example, there's a genetic condition called familial hypercholesterolemia, FH, that affects 1 in 250 individuals, including women. So it's pretty common. And this is associated with a 20-fold increased risk of subsequent cardiovascular disease. These individuals who have this genetically too high cholesterol. And you won't know about it to be able to screen and to treat and get them on preventative therapies unless we screen. So all women of all ages need to know their numbers and have their risk factors screened for. And we can't just wait to pay attention to women's heart health until after menopause. It has to begin earlier in life.
Yeah, that's a good reminder. Okay, let's get to one more here. And I love this question because of the research that I've seen around this. Pat in Washington State asks, should I take fish oil to improve my health or to protect against heart attack or stroke? So what would you say here?
Oh gosh, you have a savvy audience with all these are really tough questions and good questions. So it comes up a lot. So first of all, I think there's little evidence that dietary fish oil supplements, the ones that you got over the counter, that these do not reduce the risk of heart disease or stroke. And so lots of studies have shown no benefit for those. So I don't think there's any recommendation to take these dietary supplements. I think there's a lot of problems with them. They might not have the right kind of polyunsaturated fats, or these are often poorly refined and can get easily oxidized and just may not be helpful. And so the American Heart Association, our preventive guidelines really emphasized a healthy diet with intake of vegetables and fruits, legumes, nuts, whole grains, and fish intake through diet to decrease cardiovascular risk factors. Now, previously there was a certain type of prescription fish oil called icosapent ethyl. That's a specific type of fish oil, EPA, that was highly purified at very high doses in the study. 4 grams a day was studied in a trial. And this particular prescription fish oil, pure EPA, did reduce cardiovascular disease risk by 25%. And so that was exciting. And this was on top of statins and in patients who had vascular disease and diabetes. But in contrast, at the recent American Heart Association meeting, there was another study presented, another really important trial called the STRENGTH trial that looked at a different prescription fish oil. This one was a combination of EPA and DHA, also at high doses and also a prescription form, but this did not show the same benefit. So there was some discordance between these two studies. So how do we put all this together? I know if it's challenging for your audience, it's challenging for us clinicians too. But I think it's really clear that not all fish oils are the same, and our understanding of fish oils is still in progress. And so I think the type of fish oil might matter and the dose. But I think at this time, there's the evidence, at least is pretty clear, that the dietary supplement kind does not have the benefit. And I would encourage to get fish intake through dietary sources.
Okay. All right, let's take a quick pause on the live questions because we've got another poll question from you or for you. So we want to hear from our viewers now. Grab your phones, get ready to text in your answer. And as a reminder, all you got to do is text AHA Live to the number 22333 to answer. Now, if you've already registered, you don't need to do it again. Or if you're joining from your phone and it's easier, you can just drop your answer into the comments section. Okay, so before I pose this next poll question, let me first explain the American Heart Association's initiative called Research Goes Red. It basically asks women across the U.S. to contribute to health research. That might mean participating in surveys or focus groups or even clinical research. So with that in mind, here's our question. Have you ever participated in Research Goes Red? It's a very easy question, yes or no. And while you answer, we want to watch a quick clip featuring Michelle Amiibo. Her story perfectly captures the unique reasons why Research Goes Red is so necessary.
When I got pregnant with my daughter, and actually when we made it to the 3-month mark, I was super excited. During my 3rd trimester of my pregnancy, I went to see my healthcare provider for a pretty routine visit, and while at the visit, they told me that my blood pressure was high. Unfortunately, what happens when women get pregnant, automatically all the attention goes to the baby. And because of that, as moms or moms-to-be, we kind of put our health on the back burner. And that was essentially what I did. The assumption was after I gave birth to my daughter that everything would be okay, and it just was not. My weight didn't go back, my blood pressure didn't go back to normal, really nothing went back to normal, and the solution was just kind of to put me on medication and come back in 3 months. More could have been done, and I really should have advocated more for myself to my healthcare providers. One of the things the American Heart Association is highlighting is the need for attention to cardiovascular disease and maternal health. Cardiovascular disease is not just a disease that impacts old men. It is a disease that impacts women. And we now have the data in that shows that women who are pregnant also have a risk of cardiovascular disease. This information is critical for new moms. So when you're meeting with your healthcare provider, know your numbers, know your blood pressure, know your cholesterol, and if something doesn't come back normal, meet with your healthcare provider, talk about your needs, and come up with a plan of action for taking care of yourself.
Wow, Dr. Mikos, it's interesting. Michelle just summarized exactly what you were talking about. Once you have that baby, the attention goes there, you kind of fall away from yourself in a lot of ways. So very interesting. And thank you to Michelle for sharing her story. As far as our poll question here, have you ever participated in Research Goes Red? A majority of our audience is saying no. So is there a way that we can offer them guidance if they're interested in doing that?
Oh, yes. I mean, I think it's really important. Heart disease takes the lives out of 1 out of 3 women. And so participating in research can really help change that. And so by joining Research Goes Red, this was one of the initiatives American Heart Association has partnered with a Virally project to launch this Research Goes Red network. And so we're really calling on women across the United States to sign up and to volunteer. And there's a lot of things that can be done, participating in surveys and clinical research and focus groups. I mean, there's different aspects of this campaign. We might be testing new technologies or helping match women who qualify into enrollment into clinical trials. But ultimately, it's really, I call out everybody to consider participating because there are a lot of advantages with participating in research. While we might not know necessarily if a certain study may benefit a specific woman, we know that access to clinical trials, patients tend to have better care overall because they have more contact with healthcare professionals. So the access to gold standard of care is improved for trial participants. And plus, you're improving innovation and understanding that will help the next generation of women. And it's so important because women are not just smaller men. Cardiovascular disease is unique in women for lots of different ways in terms of how it presents and risk factors and how women respond to treatment. And we just won't understand or know enough about what responds to women, what treatments work in women, and understand these risk factors unique to them unless we conduct research that's specific to women.
Okay, so for those of you who said no, but I would like to know more, definitely think about participating in Research Goes Red. Okay, let's get to a couple of more viewer questions. Here's one from Thelma in South Bend, Indiana. Why is research so important for women's health? Well, gosh, Dr. Mikos, I feel like you just kind of summarized that one.
Yeah, so I jumped the gun. This is a great question, but exactly that, because that women have unique risk factors and related to different body size and genetics and hormones and how we metabolize drugs, and disease processes are different, and we can't just assume that what works on men work in women. And so women need to be adequately enrolled in clinical trials so that we understand the efficacy and safety of cardiovascular interventions. So we need to include women in research. And plus, we need to do research on diseases that are specific to women. There's actually certain types of cardiovascular disease that are more common in women than men. Things such as a spontaneous coronary artery dissection, SCAD, is a rarer condition, but happens almost exclusively in premenopausal women. Stress cardiomyopathy, you might have heard about broken heart syndrome, this kind of this type of heart failure that occurs after a stressful event. This is almost always in postmenopausal women. Women are also more likely to have angina, chest pain, ischemia, where their heart's not getting enough blood flow due to problems in the microvascular, something called microvascular angina. So men who have ischemia or chest pain are more likely to have obstruction in the larger arteries, which is treated a little different where women with similar symptoms tend to have dysfunction in these heart's tiniest little arteries. So really, heart disease in women can be unique, and we really need to do more research to understand these differences so we can improve outcomes in women.
I want to bring in a question from Nicole, who is in Tennessee, because you just mentioned heart failure. Nicole says, I've been hearing a lot about heart failure lately. What is it, and what are the new treatments for it?
Yeah, this is a great question because this is a really common problem. So there are two types of heart failure you may hear about. There's heart failure with reduced ejection fraction, which means the heart pump is not functioning that well. The ejection fraction, or the squeeze of the heart, is reduced. And so that can cause fluid to build up in the lungs and other organs. And then there's another type of heart failure called heart failure with preserved ejection fraction, where the squeeze of the heart's okay, the ejection fraction's okay, but the problem is that the heart and the arteries are stiff and they don't relax, and that also causes the pressure to build up in the heart. Both types of heart failure are associated with poor outcomes, and we need an attention for prevention and treatment. But the issue is that the treatment is slightly different for these different types of heart failure. We have a little bit more evidence about what works for heart failure with reduced ejection fraction. We have these pillars of therapies that include medications like ACE inhibitors, ARBs. There's these things called ARNIs, these neprilysin inhibitors, beta blockers, mineralocorticoid receptor antagonists. And then there's what's really exciting, I think what they're alluding to is there's a new class of medications that just become this fifth pillar of heart failure. And I think this is one of the really exciting discoveries. There's a class of medications called SGLT2 inhibitors. And these were a class of medications used to treat diabetes. And in conducting these clinical trials for diabetes, it became clear that these medications actually can benefit heart failure and reduce the risk of heart failure hospitalizations for people who have this reduced ejection fraction. And what's exciting is that these recent studies have shown that these drugs work even in patients that don't have diabetes. And so we have this diabetes drug that now we're using for a completely different indication and has really meaningful benefit. But I think what was really sort of exciting is at the American Heart Association meeting, again, these drugs have been used for the reduced ejection fraction type, and we had less data for the other type, the preserved ejection fraction. But there was two studies presented at the American Heart Association meeting by Dr. Bott called the Soloist and the SCORE trial that, again, looked at one of these SGLT2 inhibitors, sotagliflozin, and showed there was a suggestion that this drug may actually work even in patients who have the preserved ejection fraction. And that's really hopeful because we don't have a lot of other therapies that work in this condition. So we need a designated trial specifically in this population, which is ongoing, the heart failure preserved ejection fraction. But I'm really optimistic now that we have newer therapies for this disorder that we didn't have previously, thanks to science, including AHA science.
Let's get to a question from Sandy in Macon, Georgia. Why are women less likely to receive bystander CPR? This is a really great question.
This is so important question because, we know regardless of a victim's sex, if you see someone collapse, you need to call 911, begin CPR, and if there's an AED, a defibrillator present around to use it. Because regardless of gender, the overall survival for an out-of-hospital cardiac arrest is really poor, unless these therapies are started initially. For every minute, for example, after a cardiac arrest, without CPR or early defibrillation, the chances of survival decreases by 10%. So we need to initiate this immediately. But unfortunately, studies have shown both in real-world data and also in simulated models with mannequins or female or male avatars, or that individuals are less likely to do CPR for women. And I think some of the reasons is that there's one maybe concern about inappropriate touching, concerns about doing CPR over the chest, which includes the breast tissue. There's also maybe some concern that women are more fragile or more likely to get injured. But, these are individuals who are dying, and you can save a life. And so it is important. I know that there's some real, concerns that people might have about this, but, they have the opportunity to save someone's life. And so CPR and AED should be administered regardless of a gender or sex.
Yeah, a good reminder. And okay, our final question comes to us all the way from Canada. Meredith wants to know, how does mental health relate to heart health? Boy, that is an important question. And how are you going to answer that one? That's a tough one.
Well, there's actually some pretty good research in here. And I think this is a very good question, especially in this stressful year of COVID. So, cardiovascular disease shouldn't be addressed just as an isolated entity. It's really an integrated system where the mind, the body, the heart are all interconnected. And there has been a number of studies that show both positive and negative psychological factors impact cardiovascular health. So the negative factors we think of, as depression, stress, and anxiety, those can adversely affect cardiovascular health, whereas positive factors such as optimism, gratitude, sense of purpose can actually favorably improve cardiovascular health. So we think that there's both direct and indirect effects of how these psychological factors can actually affect the physical health, the cardiovascular health. One can be indirectly. So people who are under psychological distress may not be taking as good a care of themselves as they could. They may be using adverse coping mechanisms such as smoking or drinking too much or not exercising or not getting their regular healthcare checkups or perhaps not taking their medications as regularly as they should. So that's sort of indirect. But there actually may be direct causal factors that lead to from psychological stress to cardiovascular disease. That people under low-grade stress, there's this activation of the fight and flight response. So, people are kind of in this constant state of being revved up where their heart rates are a little bit elevated and their blood pressure is elevated. And there's this chronic low-grade inflammation in the body that can lead to a plaque that might be more likely to rupture, that can lead to a heart attack or stroke. And so there's been studies that have linked measuring in the brain on PET scans the activation of the amygdala, the body's brain center for fear and stress response. Patients who have more amygdala activity in their brain tend to have more inflammation in their heart's arteries, their body's arteries, and are more likely to have a heart attack. So there is a connection, and this is why it's important that clinicians pay attention to the whole person and address psychological well-being of their patients, because we think that intervening and on these factors can help improve physical health as well.
Yeah, and as a yoga and meditation teacher, I appreciate a lot of the research and science that's come out on this mind-body connection. So thank you guys so much for your questions, and I see some more great ones pouring in. We'll continue to address as many as we can, but right now we need to get to our newest segment called Triple Trivia. And Triple Trivia is sponsored by Crazy Cool Science, our new social media campaign that pumps up the fun in science. Science is everywhere, and Crazy Cool Science proves it. So we've got 3 trivia questions lined up to test your scientific knowledge today. All you need to do is drop your answer in the comment section, or you can text them in. And we're going to find out who's really on their game today, all right? Who's been really paying attention. So here is the first trivia question. As with men, women's most common heart attack symptom is chest pain. So this is a true or false question. And Dr. Mikos, there are a lot of symptoms that present, especially in women, but we'll give our audience a couple of minutes or seconds here to answer whether they think this is true or false. What are some of the other symptoms that we've seen in men or women?
Yeah, so sometimes it's not just a pain in the chest. It can be a squeeze or an ache. It doesn't have to be just in the chest. It can present in the arm, the neck, the back, the jaw. Patients can feel indigestion, extreme fatigue, shortness of breath. So there's a lot of associated symptoms that could be the sign of a heart attack.
So that can get confusing, I feel like, because at what point do you go, oh, am I having a heart attack, without it just being indigestion? That becomes a big question for folks.
Yeah, so, in terms of stable angina, I think sometimes the triggers are important. So stable angina, of course, is not a heart attack, but this is symptoms related to perhaps a blockage or dysfunction in the arteries. So symptoms that come on with exertion or stress, with physical activity or even emotional activity after an argument or some other kind of stressor, that would be a sign that it potentially is due to a blood flow problem in the heart, especially if it comes on with a stressor and relieves with rest. Whereas indigestion is often there's timing with meals, late at night, after a late meal, associated often with kind of an acid taste in the mouth. So, there are clues and triggers that might, point to one versus another. But I think the real message is to do a full workup to not make sure that we're not writing off women's symptoms as something else. I think a lot of my patients, women patients of heart disease, many of them were told that, oh, it's anxiety or it's stress. But actually, it was a sign of really underlying cardiovascular disease that they had. So I think it takes a comprehensive workup in understanding risk factors to distinguish the two. But yes, if you're in the setting of a heart attack, when it's sudden and at home and it's not going away, I think if there is any uncertainty, that the best thing is to call 911 and go in and be seen, because the emergency rooms are prepared to know that sometimes it will not be a heart attack. And that's okay. It's better not to miss it and to better go and get checked out than to sit at home and not have it treated, because that could potentially be fatal or lead to long-term complications. And so the emergency rooms are expecting patients to come in, and sometimes it's not a heart attack. And that's perfectly okay. And we welcome people to come and get it checked out and never be too embarrassed or afraid to get your symptoms checked out.
Okay. So our audience has sort of spoken here. Almost 60-40 are saying true to false. So what's the right answer?
So actually, women are more likely to have some kind of chest discomfort in the setting of a heart attack. So that is actually true. I think the important to know is that women can also be more likely than men to have all these other symptoms. In fact, some studies have suggested that women more likely than men are more likely to have multiple symptoms. And so I think that's sometimes distracting to women and their clinicians, that they have chest discomfort, but they're also having, shortness of breath or in their neck or their back or their arm, or they have these other symptoms, fatigue, and that can be sometimes distracting and maybe lead to less awareness that this is a heart attack. So I think they are still more likely to have chest pain, but women are also more likely to have these other symptoms too. And so awareness of all the potential symptoms of heart attacks is really important.
Okay, so that answer was A, true. Let's get to our next question. Heart disease runs in my family, so there's nothing I can do about it. True or false? Heart disease runs in my family, so there's nothing I can do about it. And this is always an interesting, comment that may come into conversation when especially talking to people who are being asked to change or make adjustments to their lifestyles, I'll say, Dr. Mikos.
Yeah, so obviously family history is really important, and we should ask patients about their family history. But that being said, even people who have a high genetic risk for heart disease, this risk can be reduced with prevention, particularly intensified lifestyle changes and appropriate, preventative therapies such as statins if indicated. So genes are not destiny. Genes do increase your risk, but they're not destiny. And there's things that we can do for prevention.
Okay, and I guess our audience is really on top of things here, even those of you who are commenting a lot of false and B for false, and that's the right answer. So good job, you guys. We do have one more trivia question for you, and here it is. What percentage of women are included in FDA trials for cardiovascular and diabetic medication? So we have some options here for you. And Dr. Mikos, can you touch on a study that was published recently in the Journal of the American Heart Association?
Yes, this is a trick question because this is my own study. So we published this in the Journal of the American Heart Association earlier this year. It was led by Dr. Shahid Khan, one of my colleagues. And so we looked at clinical trials that looking at diabetes and cardiovascular drugs that were submitted to the FDA to get approval for that drug, for that indication. So these are really pivotal trials that support FDA approval. And of course, FDA approval is the first step before these medications are just, then applied to our general practice of how we care for patients. But as you'll find from the audience, we looked at how many percent were women in these trials, and I won't give away the answer just yet. But this is a really important issue because we want to make sure that the results of these trials are representative of the patients we see every day, and that we want to understand that these drugs, the efficacy and safety of these drugs in women, if we're going to, this be part of our routine clinical practice.
Okay, I think we can go ahead and give them the answer. This one might surprise a lot of you. What is it?
Yeah, so it was only 36% of these trials that we looked over a decade period that only 36% of participants were women. So women were under enrolled in these trials, and we even benchmarked it to the prevalence of the disease in the population. We said, well, women are less likely perhaps to have heart disease. Maybe that's why they were less enrolled. But even when we benchmarked that, we found that the participation to prevalence ratio suggested that women were under-enrolled even relative to their disease burden in the population. So again, this limits our knowledge base of the efficacy and safety of these drugs in women. So that's why I encourage your audience to consider getting involved in research. If they're eligible for trials, to consider enrolling. It's just really important that we have data so we can make recommendations for our women patients.
Okay. Thank you guys so much for joining in that trivia, and thanks again to Dr. Mikos. That is it for trivia. I think we all learned a lot of fascinating facts. And Dr. Mikos, boy, you have certainly enlightened us today when it comes to women's cardiovascular health. I know, I learned a lot that I didn't know, and I'm so grateful that the American Heart Association is really leading the charge on health equity, as we talked about, and I know we'll be hosting more discussions just like this in 2021. Is there anything that you'd like to leave us with today before we let you go?
No, just again, emphasis, probably the best way to prevent cardiovascular disease is to focus on a healthy lifestyle throughout the lifespan. And women should know their numbers, even younger women are at risk. And so everybody should know their numbers of their blood pressure and their cholesterol and their blood glucose and their body mass index, and understand their family history and discuss their reproductive history with their doctors, whether they have a history of preeclampsia, early menopause, and make sure that women are paying attention to their own heart health because women are caregivers and take care of everybody else, their children, their aging family, their parents, their society, but we won't be able to care for everybody else unless they care for themselves first and put attention to their own heart health.
That is a fantastic message to wrap up with. Dr. Mikos, thank you so much for being with us today. Happy holidays to you and your family.
Thank you again for having me on your show.
We would like to end our show, I should say, with a fun little health hack that might help you chase away some of those holiday pounds. All right, and this week's health hack comes to us from Natalie. She wants to share a few yummy and healthy snack hacks. So she says, slather a slice of whole wheat toast with peanut or almond butter and sliced bananas, top with a drizzle of honey and chia seeds for fiber. Hey, I already do that, Natalie. That's a good one. Okay, the second one we've got here, place a slice of Swiss cheese on a cutting board, okay. Top with a slice of smoked turkey and a spoonful of hummus. Oh, all right. Wrap it up like a jelly roll and enjoy. Natalie, thank you so much. I like those little tips. Remember, we feature a new tip each week, so if you've got a great idea, you can always send it on to heart.org/housecalls, and you might see yours here live on the show. That does it for our show today. Remember, it is Thursday, so you can find any of our previous shows at heart.org/housecalls, or if there are more questions that we didn't get to live or have time to answer, you can find answers to anything we didn't get to on the House Calls after show, so you can look for that on the American Heart Association YouTube channel. Thank you so much for joining into our very important discussion about women's health today. This marks, by the way, our last live show of 2020. The House Calls staff is going to take some well-deserved time off to enjoy the holidays, and we're going to be back with you January 2021 to tackle the topics of the day. In the meantime, please take care of yourselves, wear your masks, get your flu shots, and continue to physically distance. I'm Sonia Azad. Happy holidays, and we'll see you next year.
Learn more about House Calls, Real Docs, Real Talk, and submit your questions at heart.org/housecalls.